BOAST Guidelines 5. Peripheral nerve injuries, accredited by the British Society of Surgery of the Hand. Number 1. Examine neurological assessment before and after reduction. Number 2. Urgent advice if laceration is near the nerve. Number 3. Nerve injury with dislocation or a fracture, reduction is done urgent. Number 4. If nerve injury is diagnosed after the surgery, explore the nerve. Number 5. While doing internal fixation, document the location of the nerve with respect to the implant. Number 6. Basic science evidence, early repair is advisable. Number 7. Post-op neurological deficit, remove the splint or plaster, reposition the limb. Still there is neurological deficit, call senior surgeon. Number 8. Painful paralysis post-op, urgent exploration and diagnosis. Number 9. Pain and progressive loss of sensation is a sign of critical ischemia. Number 10. Neurophysiological investigations and tests are rarely needed. Number 11. Brachial plexus injuries should be discussed within 3 days with the team. BOAST Guidelines Number 6. Management of arterial injury associated with fracture and dislocation, accredited by Vascular Society of Great Britain and Ireland. Number 1. Life-threatening is a priority over extremity. Number 2. Early hemorrhage control by direct pressure or tourniquet, no blind clamping allowed. Number 3. Neurovascular injury should be suspected in all injury until definitely excluded. For a pulseless deformed limb, realign under sedation and splint and re-examine. Number 5. Key signs: altered sensation, expanding hematoma or absent pulse should be explored. Pink pulseless limb arrived, assume that it is an arterial injury and observe. Capillary return can be misleading. Number 6. Devascularized limb, urgent exploration unless there is life-threatening injury. Number 7. Non-salvageable limb, early amputation advised, need to discuss with 2 consultants. Number 8. Referral code for all units of trauma for appropriate referral to the vascular unit. Number 9. If 3 to 4 hours or beyond, there is increased risk of amputation. Delayed revascularization increase the risk of myoglobinuria and increase mortality. Number 10. Unit should have duplex CT angiogram and on-table angiogram in case if they are attending trauma. Number 11. Vascular perfusion should be achieved by making shunts, followed by it you check the viability, and then after you do skeletal stabilization, and then definitive reconstruction. Number 12. There is low threshold for fasciotomy to avoid reperfusion injury. BOAST 7. Fracture clinic services. Number 1. Any new fracture should be seen within 72 hours post-injury. Number 2. Fracture clinic services is consultant-led. Number 3. Appointment and visit should have management plan. Any instructions communicate to GP and the patient in written. Number 4. There should be plaster room and an X-ray facility. Number 5. MRI, if indicated, should have a clear time scale. Number 6. From fracture clinics, a direct referral to physiotherapy or occupational therapy department is possible. Number 7. In a follow-up, clear name of the consultant should be written. Number 8. Fragility fractures and fracture fall prevention services, which consist of fracture liaison service, should be fully integral part of fracture clinic. Number 9. Rapid access back to the clinic is possible for the patient. Number 10. Information booklet and exercise sheet, if available, should be provided. Number 11. Complex regional plane syndrome should be diagnosed early, clearly, and should have an agreed protocol in the trauma department. BOAST Guidelines 8. The management of traumatic spinal cord injury, accepted by British Association of Spine Surgeons, BASS, and Society of British Neurological Surgeons. Number 1. All trauma units have a linked spinal cord injury center. Number 2. There are agreed common protocols to protect neck and spine and the clearance of spinal cord. Number 3. 24-hour access to CT and MRI is available. Number 4. Any spinal cord injury assessment should be done by a RCS scale pre and post intervention and within a time frame. Number 5. Protocol for skin, gastric, bowel and bladder and neuroprotective is implemented. Number 6. Center treating a spinal cord injury should have the ability to perform specialist spinal surgery within 4 hours. If the patient is fit for transfer, should be done within 24 hours unless the major trauma center decides against it. Number 8. The spinal cord injury protocol outreach visit should be done within 5 days of referral for patients unfit for transfer. Number 9. Psychological support should be given. Number 10. All the referral data is submitted to the National Spinal Cord Injury Database, whose website is spinalcordinjurynhs.uk. BOAST 9 Guidelines. BOAST 9. Fracture liaison services, accepted by Arthritis and Musculoskeletal Alliance and National Osteoporosis Society. Number 1. Fracture liaison services should be available at all hospitals in or outpatient department. Number 2. Should have appropriate, trained and expert facilities for osteoporosis treatment. Number 3. Clear entry criteria into the pathway, and this also includes the primary care. Number 4. The patient should be provided information on nature of the fracture, bone health, lifestyle, nutrition, and bone support or protection. Number 5. Multifactorial bone health assessment within 3 months of incident of fracture. Number 6. Risk of fall should be identified and rapid referral when appropriate should be provided. DEXA scan. The patient should be booked within 12 weeks after the injury when indicated. Number 9. There should be linked metabolic bone scan services to the system. Number 9. Good clear guidelines and communication should be achieved. Number 10. The data should be submitted to the National Fracture Liaison Services database once established. BOAST guideline number 10. Diagnosis and management of compartmental syndrome, agreed with British Association of Plastic, Reconstructive and Aesthetic Surgeons and Royal College of Nursing. BOAST 1. Routine evaluation should be done. Number 2. Clear documentation, mechanism of injury, time of injury, level of pain, consciousness, response to anesthesia, and if regional anesthesia was given should be documented. Number 3. Pain, capillary fill, limb neurology, and distal pulsations should be documented. A 1 hourly observation if the patient is at risk. If the pain does not reduce, get a senior advice. Number 5. Regional anesthesia should be avoided. It masks compartmental syndrome signs. If sign of compartment syndrome are seen, reduce the dressing, remove the dressing, limb elevated to the heart level, normalize blood pressure, re-evaluate within 30 minutes. If persist, you do decompression. Number 7. Surgery for compartment syndrome should be done within 1 hour. There should be a clear policy regarding this. Number 8. If compartment pressure measurement is done, pressure sensors should be placed at the compartment suspected. Number 9. Diastolic pressure minus compartment pressure if less than 30, either do a surgical decompression or continue monitoring as advised by the senior consultant. Number 10. Absolute compartment pressure more than 40 mmHg. Decompress unless there is life-threatening injuries. Number 11. Re-exploration of all compartment syndrome fasciotomies within 48 hours. Number 12. There is no consensus for foot compartmental syndrome. Number 13. If a compartment syndrome is diagnosed after 12 hours, this should be discussed by 2 different consultants, because diagnosis is difficult and treatment plan is difficult, and non-operative treatment also has a role.